the supply side. I'm Tony Paquin, your host, CEO of iRemedy. We are on a mission to demystify the complex and sometimes crazy area of medical supply, medical devices, and pharmaceuticals here in the United States and around the world. Together with industry insiders and professionals, we're going to dig deep, ask a lot of tough questions, and maybe, just maybe, find some answers. So let's dive in today. We've got a great guest. Before we get started, be sure to press that subscribe button. Today, I'm super excited to have with us Dr. John Su. Dr. Su is going to give us a little bit of background on the opioid disaster that we have here in this country. He is a practicing physician, and I would say also, as importantly, has invented a device that's really going to transform the world of opioid use disorder treatment. So this is something that I share a passion with. It's a disaster in this country that's often, I think, underestimated in terms of the impact that it has on our daily lives. So Dr. Su, welcome, and thank you for joining us this morning.
Thank you, Tony. Thank you for inviting me.
Right, so if we could get started a little bit and just give us a little bit of your background, as a physician. Obviously, that's a little bit of the road that you took to lead you to, involvement in OUD and the treatment plans. That would be helpful if you could kind of give our viewers just a little bit of that history. I think would help.
Sure. So for 30 years, I practiced anesthesia, chronic pain management, and also addiction medicine. And in that 30-year period, the writing of prescriptions has always been the easy part, and making sure patients take their medications at the prescribed dose and time has actually been my most difficult part of my practices.
Yeah, the compliance problem, right? I mean, in a lot of ways, the compliance problem is people not taking the drugs when they're supposed to. You get into an addiction scenario, and it's a different kind of set of problems. But it's really remarkable. We did a lot of work on capturing prescriptions of patients leaving the hospital, and like 25% of the scripts written never even get picked up, right? And then 25% of those never get taken. By the time you work your way through the script, the full compliance is definitely a serious problem.
It is. In fact, 50% of patients don't take their medications as prescribed, and that leads to 125,000 annual deaths and $200 billion in annual costs, because those patients, they actually end up in the hospital. Their chronic conditions end up being worse, and they end up having to have more care than if they took their medications as prescribed.
Right. Yeah, it's a massive problem. That's why we've had a lot of initiatives with hospitals where we've tried to, capture or fulfill that prescription right at the time of discharge or in some home delivery method and so forth. But it's just an ongoing problem. There's been a lot of attention given to this over the years. Now, you've done more, though, than being an anesthesiologist. I mean, I saw your history there, but I think at times you've invented other products and you've had some involvement with pharmacies. Is that right? I mean, you've got a fairly diverse background in addition to your medical practice.
Yeah, well, I have a long history of doing other things because I wasn't really sure what I wanted to do in life. And
Yeah.
being a doctor just fits my personality. And solving problems is another part of my personality that made me go into medicine. I mean, I've done computer programming, I've actually built houses, I've actually done hardware and software portions of medical devices. And being a doctor, we have a lot of problems in medicine, and one of the issues we've had is opioid use disorder and treating patients in pain. It's really difficult because the end user of opioids is actually the pharmacy, and the regulations stop at the pharmacy level and they don't extend to the patient level. And that in part has created a problem of its own. In fact, one of the issues I had was when I was trying to determine medication adherence by my chronic pain patients, I used to do pill counts. That means that I write a prescription for 60 pills, and they're supposed to, let's say, take 2 pills a day. And at the end, I have my patients coming in a couple days early, and I would count the number of pills that they would bring in to my office. And
Mm.
one day, for one reason or another, I was late to clinic, and I saw several of my patients scurrying from one car to another. And I happened to ask one patient what was going on. And he said that because I'm so strict on pill counts, the patient would exchange pills to make sure their pill counts were correct.
Yeah, yeah,
And
it's,
that really made
yeah.
me think about how can I make this better?
It's funny that when you think about it, they put that creative energy into it. Even at that level, they'll look to problem solve that situation. You know, when that need gets developed. You know, let's talk a little bit about that history though, because the opioid thing sort of snuck up on us, I think, in some ways, right, as a country. And it seems to me, my little view is, to a certain degree, we've almost swung the other direction. In some regards, now we're afraid to prescribe drugs. And I'm a believer that if you've like had a surgery or you've been through some situation that pain medication isn't just about you getting rid of the pain, but it's actually part of the recovery plan, right? To you'll recover a little better. But give us just a little bit of that history for people that don't know of opioid and where it came from.
Sure. Opioids have been around since the early part of the Roman days, but in 1999, there was an initiative by the Joint Commission on Hospital Accreditation. They mandated that pain is the fifth vital sign, and there was very little chance of becoming addicted to pain medications. That started from a opinion piece from a couple of anesthesiologists. Well, that actually included the fact that doctors could write prescriptions and write them freely so patients would uh, be treated for pain. And the concept that people really push forward is that pain is the fifth vital sign, and that if you're in pain after surgery, that means your doctor didn't treat you well and you should get more pain medicine.
Hmm.
That actually led to high prescribing. And then people noticed that there were several opioid overdose deaths. And so they stopped prescribing opioids, and people who were already addicted to opioids began to go to heroin and other opioids. And now, in the opioid crisis costs us $1.5 trillion and 100 opioid overdose deaths. And it's now mostly from illicit opioids. The problem with
Like the
that number,
the illicit opioids being like heroin, fentanyl, that type of product, or what are we
that's
speaking
correct,
to
Tony.
there? Yeah.
It's mostly because doctors are fearful of prescribing opioids, and these
Hmm.
patients who are addicted, meaning that they have to have the opioid for psychological reasons and also physical reasons from withdrawal symptoms, that they have to go out and get something. And the only thing that's on the market right now that's pretty much ubiquitous is fentanyl, nitrazine, xylazine, the zombie drug. People are starting to use more cocaine, amphetamines. The whole problem has blossomed.
So
And
how big is the problem though? I mean, in the United States today, do we have any idea like how many people are addicted to an opioid, for example?
well, it's a twofold problem.
Yeah.
There's people with opioid problems, and people with opioid problems can't get treatment. The number of people with opioid problems is 66 million, roughly.
66 million. Wow. So you're talking, 15 to 20% of the country at one level or another. You know,
It's about 1 in 5, so
one
about
in five.
20%. The
Really?
population of the United
Wow.
States is about 327,000, sorry, million.
Yeah. Yeah.
and 66 million. The number of patients with opioid use disorder is roughly about 20 million people.
Wow. Yeah. And so, how do you define that? OUD, opioid use disorder. I mean, what does that mean exactly? First off, is that really a diagnosis, or how do we define and measure something like that?
Sure. Opioid use disorder is a DSM-5 diagnosis from the American Medical Association, and it is a disease of chronic nature, meaning it's a chronic medical disease. How
Hmm.
we define it is it's loosely defined, meaning that it is the abuse of opioids to a point where a person has the need to take more opioids than prescribed.
It seems like the prescribing side, though, has gotten so conservative. I had my son, who I think you know, Anthony, and he went in and had some surgery done, and it was kind of minor knee surgery. But at the end of the day, they just wanted to give him Tylenol, and you can tell it's like they're so conservative, right? It's the pendulum has swung to another level because, to your point, they're just afraid of prescribing, and you know they don't want to take that risk as the prescriber. I would get, I think is a big part of it. So the system has gone in the other direction. Um, so those people, though, with OUD, I mean, are they coming from, they were prescribed an opioid at one point and then lost control of the situation? I mean, how did that get created?
Well, when pain was a fifth vital sign, doctors prescribed 120 pills a month, and people would become physically addicted, meaning if they did not get opioids, they would go have withdrawal symptoms, and withdrawal symptoms are very distracting, meaning that you get nausea, vomiting, you get jittery, your heart races fast, and your mind tends to wander. And in order to feel better, people want to get more of those opioids quickly so that they don't have those withdrawal symptoms. And
Yeah.
with the high amount of opioids that were prescribed earlier, people went out and got medications that would help them feel better. Benzodiazepines, heroin, and now fentanyl. In fact, one of the saddest situations is with the VA system. American veterans fight for our rights. I see you have a flag behind you, so
Yeah.
that means a great deal to me. We
Hmm.
have people fighting for our freedoms. They come back and they go to the VA system and they have an injury in the war. People are afraid to write for opioids, but then these patients are in pain. These American veterans are in pain. They end up, some, committing suicide and overdosing. Roughly 28 American veterans overdose and die per day.
Per day. It's a shocking to, and I'm very close to a lot of people in the VA community. We do work with the VA. I have a very very good friend who's a retired Navy SEAL commander, and those guys. I mean, they lived a hard life, man. They just did. That's the real world. They suffered mentally, emotionally, financially. They have their families are stressed, and they for the most part, the thing I find about the military, when I look at guys like this friend of mine, for example, I have a couple of very close friends in that part of the community. You find that they tend to have gone there in a sense of mission, and I find this true, by the way, with healthcare. People like yourself and others that I know in the business, they probably at some point in their life said, I want to help people. I want to go into healthcare. That's sort of, there's a lot of mission driven people. And in the VA and in the military, that is the great majority of those people. Because one thing, we're an all volunteer military. And so they tended to go there because they felt it was something that they needed to do. But boy, once they come back and get out, they get ground. The system is just a grind, and it really doesn't meet those needs. And I don't know about this specific problem. That's why we're talking today. But I just know in my other experience of some of the other things that they go through, with emotion counseling and, the inability to sleep. I mean, there's just so many things that some of these guys come back and have to struggle with. It's really, really a problem. And it's hard to imagine losing 30 veterans a day today's society. Of all the problems that we have to talk about in the world, we're not talking about that problem. And I just find it astounding that we could be talking about 10,000 people a year who have served our country, and we're not kind of more focused on it. We seem to argue about the wrong things a lot, I think sometimes, just sort of my little rant there, but I can see how this would be a huge problem. And knowing the VA the way I do, I could also see how they would be reluctant to send a guy, a treatment plan or more opioids, right? I can see them being that same pendulum that swung the other direction and said, no, we're just going to not do those kind of painkillers. Sort of a system response rather than a human response to the problem.
Yeah, there's two concepts that I need to talk about. One is that, the VA system tries its best. There's 283 pain clinics in the VA system, and they treat about 6,500 patients. But there's 418,000 veterans, American veterans, who have opioid use disorder that are at risk and they can't get treatment. We need to bring treatment to them. And the second thing is, there's a drug out there that the FDA just recently cleared. It's a very quick acting, very highly potent opioid that the military helped push through because when you're in pain and you have somebody shooting at you, you take care of the pain, you can protect our country.
Right. Yeah. What drug is that?
I don't recall at this moment,
Yeah.
but there
But
is a.
it creates the same consideration, right? That you have to have a long-term management problem.
That's correct.
Once you go down that road. Yeah. Yeah.
And you have to treat patients very, very successfully for opioid use disorder. And one of the problems is many of those patients can't get treatment. Only about 10% of patients get treatment from the VA system to jails to the American population. And
Yeah.
that entails something that most Americans don't understand is that when you opioid replace the drug that's causing the opioid epidemic, many people don't understand how that could be possible. But in fact, that's our best treatment today. We can reduce the opioid overdose problem by greater than 50%, but only one third of OUD clinics prescribe it, and only 1% of jails prescribe it. And believe it or not, jail operators still believe that incarceration is the best way to treat opioid use disorder. And that simply is not true.
No, I can see how that wouldn't work. And plus, at the end of the day, particularly if you're talking about a jail versus a prison, at some point that prisoner is leaving the jail, and then whatever support system existed in that jail no longer exists out on the street. So you have the recidivism problem, right?
That's right. In fact, at 30 months, recidivism can climb as high as 75%, relapse 75%. In 6 months, the reincarceration rate can climb to over 60%.
You can see how it's not sustainable. There's so many things in healthcare today that I believe we're at a tipping point. We've seen these problems grow over the year, but if you come back to the OUD discussion for a moment, just consider the financial impact, right? The loss of people working in society, the destruction caused by really in a backdoor way, you're supporting the illicit drug trade and you're getting all the spin-off negative effect of that, homelessness, crime, all the other problems that come with that. It's a very, very, very expensive problem that just simply isn't being treated. So the treatment drug that you're talking about is Suboxone, right? Is that the approach that you're thinking of?
Yes, there's three different drugs that are FDA approved for the treatment of opioid use disorder: methadone, Suboxone, and naltrexone.
Yeah. So, like, how are they different than the opioid? I mean, what makes them a treatment?
Well, Suboxone is a class 3 drug that's called buprenorphine, that's a generic name, and it binds to the opioid receptor, which is called the mu receptor. It binds very tightly, but it doesn't cause the high that most patients with opioid use disorder are striving for. Methadone, which is a class 2, it does the same effect. It's longer acting, binds to the mu receptor stronger than most opioids, and that prevents people from the high. And when you change the mentality of patients, it actually reduces their desire to acquire drugs. Now,
Yeah.
tretinoin is the other drug, and it actually just blocks the mu receptor, and it can be done it can be injected underneath the skin that can last anywhere from 30 to 60 days.
Interesting. Yeah. It's like an Ozempic for OUD. Yeah, just removing the desire sort of idea, right?
Yes,
Yeah. Yeah.
it works. All of the drugs work, but part of the issue is that these are drugs that support the physical aspect of OUD. You actually have to add in the psychosocial support as well. And you talked about homelessness, time, and not having a job. One of the biggest problems that people have in not getting treatment is simple transportation. If you live in a rural area, many of these patients are of low socioeconomic conditions, and they don't
Hmm.
have the bus money or the time to take a bus to come to
Yeah.
my clinic or to go to a OUD clinic. And there's very few OUD clinics in the country, and
Yeah.
they can't get treatment. So the easiest thing to do is just to go back on the drugs that they were abusing before.
Yeah. Go back down. The treatment clinic is the guy down at the corner that's selling fentanyl. I mean, that's what they have access to, right? It's a VA thing. We've talked about this in other scenarios where one of the things about the VA many years ago is the original system was built around VA hospitals, right? And that kind of worked. Like you'd have a military base, and then people would retire there. There'd be a VA hospital, and the community would be served in that environment. But over the decades, the veterans, like everybody else, they moved all over the country, and some may live in Orlando, but others may live in some small town out in the middle of, South Dakota. And so that creates that access problem that you're talking about. And I know the VA has been responding to this. They've been creating these more ambulatory clinics and other remote solutions to try and address that. But you have a spread out population, is your point, and it's that same access issue of how do I get from where I live to the treatment clinic, and I would suspect that you're talking about in the traditional sense. The treatment clinic requires a lot of surveillance. By that I mean like you have to go frequently. It's not like you can go once, come back in 6 months, but you probably like in your clinic experiences, I would assume that's the way it was built, right? They came in, I don't know what, once a month, once every 2 weeks, or how frequent were you seeing those patients?
Well, it depends. If they're in distress, I see them every other day. If they're in less intense withdrawal symptoms, I may see them every 7 days, but usually, typically, every 2 weeks to 4 weeks, I see these patients. And
Yeah.
the problem has always been we hand these patients a bottle of pills, and I have no control whether they take one pill, 10 pills, or the whole bottle of pills. It's
Hmm.
very, very important to treat pain. And
Hmm.
part of the problem with opioid use disorder is that many of these patients can't get adequate health care. They don't feel good, and it could be because of hypertension or diabetes or as in the case of veterans. And first thing they do is they grab an opioid to make them feel better. And it only takes 7 days to develop an opioid problem. It takes about 30 days to develop opioid use disorder. And then it takes about 12 to 18 months to actually go into successful opioid use disorder remission.
Wow. Yeah. By the way, how did you get going down the road of OUD treatment? I mean, I know tons of physicians and surgery centers and hospitals and pain medication people. Pain med doctors who all are great people doing wonderful work, in virtually every case. But I don't really know people that have taken on that passion for the OUD situation. I mean, how'd you end up going down that road?
I'm not trying to preach, but
Yeah.
in
So,
2018, I got baptized in the River Jordan in Israel. And then
okay.
coming back, I was sitting in church, and the minister asked me, "What are you doing to evangelize? What are you doing to help people?" And I was helping one person at a time. And then I started thinking about how I can help a lot of people at one single swoop. And I started thinking about my background and how I can help people. One of the big issues is a barrier to treatment. And so I put together something where I could monitor when a patient's taking their medications and when they forget. And I created a system so that it's like a bank mobile app that connects to a bank ATM for pills at home. So if you don't
Kind of
take your pills, the doctor hears about it, and family and friends can find out about it, and they can help the person, remind them to take their pills. That way, you know, I can actually send the pills to the patient's homes directly, because if there's unused pills or they try to break into the device, I can destroy the pills immediately. That means
how
a chain
many
of custody is
Yeah, how
maintained.
many? So we're talking about the iPill dispenser. Yeah, I want to dig into that a little bit. By the way, on the River Jordan thing, Keisha and I went there. We went to the Jordan side, which is a really interesting experience. I'll share with you someday, but very dramatically different between the Israel side and the Jordan side of that river. A pretty interesting location, phenomenal history, very cool experience. But going back to the iPill dispenser, because that's really what we're talking about, what you were just describing, right?
Yes.
So I want to kind of cover that a little bit. That's how we met. I think it's like a super exciting and it should be a transformational device in treating this problem. But how many pills can you put in the dispenser? And what I'm really driving at is what period of time would that cover a typical patient? Because you can give them the dispenser, then they can go home or go back to their home community, right? So what does that work capacity wise?
We can give 30, 60, 90, 120 pills in the dispenser itself. So we would actually mail it to the patient's homes, eliminating the barrier to transportation or childcare, so they don't have to come to my clinic. We can do the psychosocial support with telehealth and the physical support with the iPill dispenser sent directly to their homes.
Yeah, that's just amazing. So, for everybody's benefit, the way the device works, and I'm going to screw this up so you can correct me when I get this wrong, but the device is tied to an iPhone, presumably, or I don't know if it works with other mobile, but I think of it as with an iPhone. It has so therefore it can use the biometrics of the phone device. So it knows it's going to dispense a pill to the proper person, right? It's just not, somebody can't pick up the device and hit dispense and out comes a pill. They have to go through the biometrics. I think about it. I fly now, I use Clear. They have the Fly Clear system, right? The normal system that you used was you'd go to the airport and you give your fingerprints on a device, and that would clear you, and they walk you up to the front of the line. Now, the last time I flew through Louisville, smaller airport, they don't use that device. They use your phone for your biometrics. So it's getting to the point where you walk up there, you have the app, they scan your phone, and they consider that biometrically equivalent to their other main device for security purposes. And in a lot of ways, it's similar to what you're talking about, right? That you're able to use that device to do a biometric verification that when you say I've mailed this to somebody, you're getting to exactly the right person at that point. And the device will dispense a pill or pills, I guess, depending on how you set it up, with the right potency of pill at the right frequency. Is that a pretty fair description?
That's correct, Tony. You did a fantastic job in describing it.
Thank you. Yeah, I think it's very very cool. So then, but then as you were pointing out, let's say I'm the patient, and we have all these different circumstances. So one is if you sent me the bottle of pills, well, one of the problems, like if you go to my house, I got bottles of pills everywhere. For one thing, it's my wife and I. There's no children around. It's not an abuse problem. But in this case, if you're to send you know, a bottle of 30 Suboxone pills and a guy sits it on his counter, I mean, there's all kinds of opportunities for abuse, right? By that person, by somebody in their household, by children, or the other opportunity is they could sell it down the street or something, right? Those are, but all that tends to go away with the device, correct?
That's absolutely correct. Only the prescription holder can have access to the pills at only the prescribed dose and time. We are actually preventing the 1 in 4 opioid overdose deaths in children in the United States. 1 in 4 opioid overdose deaths involves children and teens. So
No
it's
kidding.
to prevent that. And the way we do it is by taking a face print government ID and using the phone, because we actually confirm that it is the person who owns the phone who is of that same name that is going to be able to receive the iPill dispenser at their home. And they're the only ones that can use it. So let's say my wife could not use my phone because her face doesn't open my phone, number one. And number two, her face does not match what's written uh, in our phone app that allows confirmation of who the prescription holder actually is.
I see. So I didn't know quite how that works. So using my example again, if I were the patient, you're somehow taking my driver's license photo and getting it into your system somehow so that then it will sync up the two. It will know that not only do I have this device that I can open, but I'm actually who I'm supposed to be to have that device. And then once you've connected me facially to the device, then every time I access the device, you know who that person is, and you can release the dosage to them.
That's correct.
Yeah.
After registration, it's basically your face and hit dispense, and you get your drug. And if you don't get your drug or you don't take your drug, the family, friends, and the caregiver can be notified, and they can help you remember to take your drug.
Right. It's all being reported in the cloud, so to speak.
Yes,
So going back to this telemedicine idea, which, we're seeing this in all kinds of other far less life critical scenarios, right? But yeah, you got it in weight loss, you have it in, male performance enhancement, you've got it in skincare, dermatology. I mean, there's a lot of these sort of telemedicine tied to a prescription models that we're seeing out in the market, right? But in this case, because you made a comment earlier, the drug is really just part of the treatment plan. You've got to have some sort of care management taking place. I would assume like counseling or oversight by the clinic or by a licensed healthcare provider, right?
that's correct. And we need to treat our patients holistically. There's not a magic pill to treat OUD. In fact,
Mm-hmm.
I think it requires a change in your passion. I've had very successful patients who have gone into remission. I had a patient who was developed opioid use disorder after an athletic injury. This is a young patient. This patient was addicted to opioids or had opioid use disorder. It took me 12, 13 months to change her desire to acquire opioids to actually programming. She now has a startup, or the patient has a startup that programs for the sporting event that she originally was injured for, and she has been in remission for the last several years.
Really? Yeah, excellent. So, in order to accomplish that, what you have to do, using the Suboxone idea, for example, so you've got a patient, they're addicted or they have their OUD, the opioid use disorders. They have this problem. They get involved in the treatment plan, and you have the Suboxone, or you might choose some other drug, but use that as an example, and you prescribe it to them. That takes away, desire to go get an opioid, right? And that takes a while. Like that's not like a month and we're done kind of situation. This is, to your point, let's call it a year, might be 12 months of treatment. And during that time, you're somebody is counseling them and helping to move their mind from, hey, how am I getting my next pill, to, well, what am I going to do with my life? What's that passion going to be, as you described it, right? And then at some point, like in her case, then I take it, when you say she's in remission, she's off the whatever drug might have been used in her case, right? Is that the way it works? It's not an
Yes.
ongoing forever kind of deal.
Yes, she may be on Suboxone for a number of years, but we eventually weaned her to a very low dose, and we will probably take that out or discontinue it later on. I mean,
Yeah.
many people are concerned about the cost of treatment. It's $1.5 trillion a year for 112,000 opioid overdose deaths. Each
Yeah.
death it costs our country over $13 million if when you do the math, and just just the pills are nowhere near $13 million. In fact, we
Oh,
can use
yeah.
generic pills.
Right. Yeah, the pills are readily available. But the ability to dispense them, that fear that providers have in prescribing an opioid, I'll bet you that carries right over into a Suboxone treatment program. They probably have the same fear, the typical provider situation, right? They're worried about these things. They're worried, frankly, about their personal exposure. I mean, there's a certain amount of what I call defensive medicine. That's a big part of healthcare today. And frankly, in some ways, you can't really blame these guys. You got doctors and they got their livelihoods and they don't want to make mistakes. And they may not be an expert in the conversation we're having right now. They're doing surgery or they have some other specialty. And so, but I mean, I know my clients in the world I run in and all these physicians, I would say the ones, I would say universally, they would be hesitant to prescribe a product that they didn't have that other control strategy in place. That if they're just going back to giving me an orange bottle filled with 30 Suboxone pills, I could see how most doctors I know would resist that, right? So what is the payer? You talk about the financials, but in that case, the iPill dispenser eliminates that concern because now you don't have the opportunity to abuse the prescription of the Suboxone or whatever the other treatment plan is. So that eliminates that. The device, by the way, you don't really refill, right? It's disposable. Is that the idea after you've used it?
It is. There's something called the Drug Supply Chain Security Act, DSCSA, and anything that touches an opioid, any residue in a container needs to be destroyed after the end of the prescription term.
Yeah,
So, we destroy the iPill dispenser after use
yeah,
automatically, actually. So,
right.
no one in the household, no one else can abuse, divert, or accidentally overdose. And as I spoke about earlier, 1 in 4 opioid overdoses involves children and teens. It's very, very unfortunate.
Yeah, that's horrible. Yeah, how could a child have this problem other than they somehow picked it up from an adult member of the household? I mean, it would be rare for a 9-year-old to have been prescribed an opioid, I would assume, right? So
Well,
it tends,
well, you'd be surprised. There
yeah,
are children who are addicted to opioids because they're very smart. The child-resistant cap, which was coined in Canada by Dr. Henri Briault in 1956, I think it was. You know, the children today with the smartphones and with in the internet.
Yeah.
They are so smart. They can open a box. You can have a 2-year-old open a child resistant cap nowadays, and
Oh,
they
I
open it.
believe that.
Looks like candy. I don't blame children.
Yeah.
It's such a problem that we stop our regulatory issues at the pharmacy. And I realize that there has to be some freedoms in our life because that's the basis of our country. But with
Hmm.
opioid use disorder, with pain, we have to treat pain. We're neglecting chronic pain patients. People are in pain, and many pain. We actually reduced our life expectancy for 3 years straight before COVID because of suicides and opioid overdoses because we weren't treating pain.
Hmm.
We need to treat pain. We need to treat opioid use disorder. Otherwise, we're not going to get any better. There was a paper that came out today. Provisional overdoses actually dropped 3%. And that 3% I attribute to the increased advertising and marketing of getting patients treated for opioid use disorder.
Hmm. What is the
It is effective.
payer side of that? I mean, you talk about the financial impact. The trick is always, though, how do you connect that great cost to society to an insurance company paying for the treatment plan? I mean, that connection of the macroeconomic cost to the individual payer of some sort. Now you have these different segments. In the VA, you got the VA, right? And I know you've got some initiatives in the Department of Corrections. But if I go to my local, if I go to you, does my United Healthcare Insurance pay for OUD treatment? I have no idea. Yeah.
Very rare do you get a commercial payer to pay for opioid use disorder because it's costly and
Costly.
it's their profit, and so therefore many, in fact I would say most, do not cover opioid use disorder treatment, mental health disorder, behavioral health disorder
Mhm.
treatments. In
Yeah,
fact,
and look, I don't want to like overpitch the device, but I will say that part of the reason the commercial payers may not be inclined to do that is without a good control system in place that can be replicated and duplicated around the market. I could see how the failure rate is probably very high, and that would be something that would really discourage a commercial payer from paying for something that frankly has a high failure rate. That's my guess. I think if the treatment plans progressed and things like the device was out there that managed it in a predictable way where you got better outcomes, then the commercial payer might, emphasis on might, but they might be able to connect the dots. That just says, well, it's expensive, but it's still cheaper than the alternative, you know.
that's
And
very true. In fact, each death costs $13 million, and I
right,
don't think any insurer would be willing to take on that risk.
yeah,
However, if you look at the reduction in opioid overdose deaths by simply using methadone or Suboxone, the cost of the drug isn't as much as $13 million, but the cost to society is about $13 million.
hmm,
Medicaid pays for 70% of OUD treatment because many of these patients have lost their jobs. They do not have income. And we need to take care of our fellow Americans. So Medicaid steps in and takes care of it.
yeah,
What we've done at this point is with the opioid litigation settlement, there's funds out there. And many of these programs, as you say, they don't have a successful way to treat opioid use disorder. So now we're presenting to them a way to help manage and successfully treat opioid use disorder. I think it's important because we're actually showing the insurance company the data that we can actually be successful because the papers are already out there. We just need to make sure the patients take their drugs,
yeah,
and we can save the insurance companies the emergency room visits, the healthcare utilization to their doctor or their psychologists or their psychiatrists, and we can actually save them money. We just need to provide the data. Our data is coming. Our data is going to come from a commercial pilot with a jail system and a opioid use disorder clinic in the United States.
Yeah. Yeah, I could totally see that working. The device, by the way, as you continue to advance, I would bet in the years to come the cost can come down, right? Because to your point, the cost of the pill is nothing. I mean, it's something, but it's generic and it's affordable. I don't see on a cost basis the drug as really being a hurdle in this case. And you've got the settlement funds and other sources of funds there, but I don't see the drug as an issue. And if you're using a telemedicine approach to dispensing and managing and care providing, that's also highly efficient, right? That's enabled by the device because the device causes compliance. And I always like to notice when you talk about it, you talk about getting the patient to take the pill. People think it's a lot of making sure the patient doesn't take too many pills or doesn't abuse, which clearly that's a concern. But I think it's important to recognize the equal concern is just the lack of compliance, like not taking the pill, right? In this case, the device monitors it both ways. And now you've got data. The business is always about the data. I mean, you could easily have this data drop right into a Epic EMR system if you wanted to do so, where the world would know, the care providers, the family members, whoever would know, what the compliance situation was, either direction. So, so the question is, how is the device being manufactured, and how might that cost come down over the years? I mean, is there an opportunity for that? With so many other things we see, with volume comes efficiency.
Right. And to answer your question, yes and yes. We're actually making the device in Mexico, not China, to avoid supply chain issues. There's foundries for the printed circuit boards in Mexico and the chipsets in Mexico, so we can move it up to the United States to different places within the United States, which means that the cost of transportation is reduced. In the business plan that we've made up with the iPill team, we're trying to reduce all the different cost structures so we can make this as inexpensive as possible to approach as many patients as possible so that this would be adopted by insurance companies readily and Medicaid regularly.
Yeah. I'm a huge proponent of what I call de risking the supply chain. And we talk about it all the time. But, Mexico this year became the number one importer into the United States. They surpassed China, not in just healthcare, but just overall. I think they are, a greatly underestimated resource. And, they're friendly, they're right across the border. To your point, reliability of supply chain, lack of transportation costs, even environmental impact. You're not running something halfway across the ocean. And other reasons why I think better labor management, just a lot of other resource management advantages. So I definitely commend you on that. I'm always happy to hear about things happening in these more America-based countries. You go all the way to South America, Canada, but Mexico is going to be a player. No question about that. I think. The other thing that might happen with the iPill device, have you thought at all about other drugs? I mean, this is an obvious application, but before you and I ever met, I mean, I spent years with the compliance problem. Like that's everybody's problem. So it's not just it really it it screams in the OUD world, but really I would think there's probably some other high value targeted areas where you could justify the device.
Absolutely. With OUD, patients take too many pills. We were called by the National Health Services in North Scotland because they have 1 million patients with mild cognitive impairment. That's pre dementia. Many of those patients forget to take their medications. They're at home. So they called us and wanted to treat their chronic patients with 5 to 8 different types of pills to remind those patients to take their pills. And at the end of the year, we'll have another product for the home that we can mail to the home for these patients to do it. The important part of that is that 98% of people have a smartphone in the United States,
Hmm.
and most of the people in North Scotland have a smartphone as well. So we can actually use that smartphone for biometric authentication to make sure that it's the patient who is taking the pills, and to remind them to take their pills, because when the phone rings, most people answer it.
Yeah. Yeah, it's interesting when you think of the tech platform, if you will, of the iPill dispenser. A lot of the tech exists in the iPhone environment, right? In the cloud, in the iPhone, or in the mobile device, right? The device itself, the iPill dispenser, is relatively simple. I don't want to, draw a picture that it is there's not a lot to it, but it's sort of elegantly simple, which is important because that gives you reliability and consistency, and you got to keep that manufacturing cost down. It's not like you're building I would assume there's not much of the way of a programmable computer chip into the iPill dispenser. There's got to be a little bit of something there, but most of the power would exist in the mobile device, presumably, right? And that does give you that ability to ride on top of the mobile platform of the world that exists. So it's an interesting deal. My mother long ago passed away, but had Alzheimer's. And, we lived through that whole experience from the early stages all the way through. And yeah, there was, clearly a time when she was just forgetful, not really in full dementia, but still very much operating on her own. She was a very independent woman, and that was very, very important to her. And you always were trying to extend that as much as possible because ultimately, when she lost that independence, is when she lost the will to live. Honestly, so the more we could equip that, the better off we would be. But the compliance issue, I could really see fitting. I guess in that device, would you be you'd have to accommodate multiple pills, or is it a different configured device? Is that
It's
is
a
the
different
question?
configured device, but we can handle 5 to 8 different types of pills to dispense
Mhm.
over the correct prescribed times. I mean, the device will actually save money, because if you can have patients at home taking care of themselves, that's essentially very little cost. But when they go into the hospital, then the costs start to rise. And if we can delay that, perhaps we can save Social Security, or reduce
Oh,
healthcare costs to improve the economy.
it's something like 80% of your healthcare costs is in the last, 3 to 5 years of your life. And it has to do with going to the hospital. And, love my hospital clients, but they would agree with me. But it's very expensive to go in and sit in that hospital bed because you're really managing a relatively minor because some aging person didn't take their meds or forgot something or fell down, and the reflex is they hit 911. And before you know, you trigger this very expensive process, right? That's an area where the insurance companies are very focused on care in the home. That's the model of the future, no question about it. Yeah, even assisted living facilities have that type of need.
Absolutely. In fact, because 10% of hospitalizations are due to lack of medication adherence, it's so
Mhm.
costly. And if we could reduce it by half to 5%, I think it's a winning strategy.
You could do quick, napkin math on that, but it'd be, you know, $5,000 a year times everybody over the age of 70 would be basically the way it works out. I mean, it's incredible, right? You get to that level, and people just you can run up those bills so quickly, and it's so expensive. So that's an exciting area, but that's sort of the next step for you. I mean, the first thing is to focus on the device as a OUD treatment plan, and then to evolve it into the broader market, right?
Yeah, that's true. And what we're fighting against is education and how people think about their department. When you think about the cost of the iPill, it's minimal compared to an overdose death. But people always think about their department, not about the enterprise-wide budget. And
Mhm.
the device itself, there's 3 billion pills that are prescribed a year. Sorry, 3 billion prescriptions prescribed in the United States. Simply by saving 10%, we could save the cost of the U.S. deficit.
Yeah, that's the remarkable thing. I got to tell you, I often tell people, amidst all the crises of the world that we live in today, there is a reason to be optimistic. And that is because of these inventions that are coming along, because you really can have that kind of impact. And I think the day will come, and 10 years from now, people look back and they'll go, "Oh yeah, I can't believe they used to give people those pills in a bottle and hope that they took it." Right? That would be an archaic way to think when you really consider the right way to do something. You know, you can easily have that kind of impact. I do think the market is pretty aware of the compliance problem, and there's been a lot of focus on trying to figure it out. And what you have now is what people do today, like PillPack with Amazon. They have the compliance packaging, so it'd be like 2 packs a day, and it's a little package, with the pills that your vitamins, whatever it is that you're taking, right? But it's not intelligent. It's not, obviously. I mean, it's a little packet. It's not connected to the cloud. So at the end of the day, you have no idea whether the people took it or not. It's a convenience, thing, and that's nice, but it's not a patient compliance tool. And the only way you can do that is through cloud management. In order to have cloud management, you have to have an electronic dispense device of some sort. So
It's true. And, with patients with opioid use disorder, they want to take too many pills. So, one of the key features of our device is that it actually destroys the pills if you try to tamper with the device and at the end of 30 days. So, there's no excess pills. Did you know that there's 3 billion pills, opioids, entering our society because 42 to 71% of post-op opioids go unused? They just sit in the medicine cabinet. 5% of patients have an open bottle of opioids that they didn't use in their homes. And
yeah,
believe it or not, 50% of patients who actually overdose don't have a prescription for opioids if they overdose on prescription opioids.
hmm yeah.
That
You think of
diversion.
like I've had like hydrocodone or various things like that because I have kidney stones too often, and every now and then I get prescribed some pretty powerful meds for them, and then if I don't use them, I'll keep them because I'll be thinking, yeah, if I need them someday down the road. But to your point, that's not what you're supposed to do. If you had the device, it'd be well, you could use the two or three you want to use, but when you're done, they're gonna instead of just saying they're expired, you truly expire them, right? How do you destroy it? How does the drug get destroyed?
Well, before I answer that, let me tell you kind of an interesting, funny story.
Yeah,
There's no key uniform way to destroy opioids. Many patients just throw them in the trash or flush them down the toilet.
yeah.
Well, believe it or not, when you flush them down the toilet, the Chesapeake Bay oysters and the mussels in Washington State, they have trace amounts of hydrocodone and oxycodone in
Yeah,
them.
I've heard this. Yeah,
Yeah.
yeah,
And so
yeah.
the way we destroy it is we coat the pills that are inside the dispenser with long chain carbon, and we accelerate the process. So they do not. If a person takes the slurry that we create, it's not absorbed in the gut because the molecule becomes so big. And it's essentially how we treat opioid overdoses today. In a patient with any kind of drug overdose, if there's pills in the stomach, we put a tube into their nose and put charcoal, which is essentially long chain carbon atoms, into their stomach to bind the medications and dissolve the medications. We
Oh,
do the exact
interesting.
same difference. We just
Really
add a accelerant in it.
interesting. That's really interesting. Yeah, I was wondering when you were describing, I'm like, oh, do they put something in that melts it or something? But that wouldn't work anyhow because you'd still have the active ingredient. What you're really doing is taking away the active ingredient effect, I guess is a way to think of it. I had no idea. That's really interesting. So when
Yeah,
somebody has that in their stomach, you don't just pump their stomach, you put charcoal in instead?
yeah.
Yeah.
That's essentially what
Yeah.
we do. We bind the drug and we can suck out their stomach, but it's usually not effective.
Hmm.
Binding the drug with charcoal is probably the most effective way we can treat patients at this point,
Hmm.
or give them an antidote to the medication side effects or
Yeah.
medication effects.
Yeah. Now, do you still see OUD patients, or how are you managing that process today?
Occasionally, I do. I have long-term patients that I occasionally see. I'm focusing on this project and also my other project. I created a pharmaceutical. It's an opioid plus a respiratory stimulant combination drug to make the opioid safer and potentially better and potentially abuse deterrent. That means you can take your opioid and not have opioid-induced respiratory depression. We have a $1.9 million NIDA NIH grant, and we're due to start a clinical trial at the Cleveland Clinic later in June.
Yes. So we were talking a little bit about other applications and some of the other work in the OUD world, but that led you to doing some inventions in opioid respiratory impact. I believe you've got a drug under testing there. Tell us a little bit about that.
So with ingestion of opioids, it binds the mu receptor, and the mu receptor actually can slow respirations to a point where you stop breathing. And when people say that you overdose on opioids, it's the respiratory depressant aspect of opioids that actually causes a fatal overdose. So what I've done is actually added a FDA-approved respiratory stimulant in combination with the opioid. That is considered a response to opioid induced respiratory depression. And at very high doses, it can actually deter more abuse because um, it actually causes a fight or flight response and a great deal of anxiety, which most patients with opioid use disorder do not like. So we can make a better, safer abuse deterrent opioid, and that's what we are geared up for. 90% of the generic opioids that are prescribed in the United States include hydrocodone and oxycodone, and there's no safety measure attached to them. I mean, we treat side effects, including nausea, vomiting, itching, and constipation. But the most deadly side effect we ignore until now.
And that's the respiratory impact.
That's correct. And we're doing the study first in humans at the Cleveland Clinic. And
Awesome.
once
Yeah, that's fantastic. That'll be interesting. So that'll be out. You'll start that test. How long does that process take to play out? Is that a year or two, or how
Now
long
it's
does it
going to
take?
take about 18 months. We're a 505(b)(2) FDA pathway. We actually have a FDA breakthrough designation that we've been offered. So hopefully it'll be much faster than that. The
Hmm.
reason I hope that it's much faster is because the faster we get treatment for pain instituted in the United States, I think we'll have fewer patients going out to get illicit drugs.
Right. Yep, that makes total sense. Well, I appreciate all your time today. Love the story. Love everything you're doing at iPill, and really appreciate your own mission and passion for this market. It's super important and really valuable. I'd like to thank everybody for joining us today on the supply side. I'm Tony Paquin. It's been a pleasure sharing insights about the medical supply and healthcare industry, and especially today, spending time with Dr. Sue. Be sure to join us next episode as we explore further the dynamics of the medical supply chain and the broader healthcare industry. Don't forget to like, comment, or share if you enjoyed the episode. And thank you again, John, and I look forward to seeing you very soon.
Thank you very much, Tony, for having
All
me.
right, my pleasure. Take care.
All right, bye bye.
Bye bye.